Hey everyone, it's Dr. Prepper. I'm back. I received a lot of feedback about last video saying that my voice sounds a little strange. That was basically because I was recovering from a sickness. I had a very bad cold, but I didn't want to miss out on delivering a video for that week. So I'm back with another clinical question for us to discuss. Let's go get you that PG seat. Since last week we discussed the various ways in which calcium metabolism is affected, I thought we'd look into some of the drugs that are used these days for osteoporotic therapy. So treating osteoporosis is very important because it helps to prevent pathological fractures, increases bone strength, and overall helps individuals after a certain age. So let's look at some of the new drugs that are coming in that we use for osteoporotic therapy and look into their finer details. So the question that has led to this week's discussion is which of the following drugs is based on the rank OPG pathway? Adalimumab, Bisphosphonates, Denosozumab, or Apixaban? So the correct answer to this question is actually the third option C, which is Denosozumab. So now how did we arrive at this question? If you want to know what the rank OPG pathway is, you should refer to last week's video where I have explained calcium metabolism and helped to explain the action of the rank OPG pathway. Knowing that pathway and learning from that video will help you understand the action of the drugs that I'm going to talk about much better. So let's look into the topic of discussion for today. So the topic for discussion today is osteoporotic therapy or drugs used in osteoporosis. So the first and most basic drug to be discussed in this group is obviously vitamin D. So how does vitamin D help in osteoporosis? It increases the intestinal absorption of calcium. It increases reabsorption in the renal tubules. So therefore causing a general increase in the calcium levels in the body. It ensures more and more deposition of calcium in the bones, therefore increasing their strength. So what is the dose of vitamin D? It is usually given in the form of granules or depura, which is the liquid form, or it is called as calcirol or bluevit granules. So the dose is 60,000 international units once a week for 6 weeks, followed by once a month for 6 months. This is a full course of vitamin D. Some people like to stop with just once a week for 6 weeks, and some people just want to continue it long term for once a month. But this is a proper full course of vitamin D, 60,000 international units for 6 weeks, once a week, followed by 6 months for once a month. So that is how you treat with vitamin D. So coming to the next group of drugs, that is bisphosphonates. Bisphosphonates usually act by inducing osteoclast apoptosis. It reduces the resorptive ability of whatever osteoclasts may have survived. The three most common drugs are alendronate, risedronate, and zoledronic acid. Of this, alendronate and risedronate are oral options, while zoledronic acid is an injectable option. It's an injectable. Pardon my handwriting. So the most common oral preparation is alendronate. It comes in the commercial name of Osteoporosis, and when we use it in practice, we usually give it 70 mg once a week for about 3 months. So that is how alendronate is given, and that's how bisphosphonates are used. So you might often get questions from how bisphosphonates actually act. So they target a specific metabolic enzyme, which is farnesyl pyrophosphate synthase, or FPPS. This is the abbreviation and that's the full form. So this prevents the normal modification of proteins which is required for osteoclast function. So remember, it affects osteoclasts. So how it acts is this drug goes and becomes integrated in the bone mineral. In the bone substance itself, the bisphosphonates go and integrate themselves, and when the osteoclasts are trying to resorb this bone, this enters the osteoclast or is taken up by them, and they induce osteoclast apoptosis by targeting this enzyme, and that's how they cause decrease in the number of osteoclasts and decrease bone resorption. So a very recent advance in osteoporotic therapy, a relatively recent advance, is Denosozumab. So as you can tell by the name, MAB in Denosozumab stands for monoclonal antibody. So this is a monoclonal antibody which has an affinity for rank L. Rank L stands for rank ligand, as you would know from the previous lecture. So what Denosozumab does is when it is in the body, is it binds to these rank ligands when it administered. So now we will look at the mechanism of action of Denosozumab. How exactly does it cause decrease in bone resorption? So like I said, Denosozumab reacts or acts by binding to rank L. Once it binds to the ligand, it inhibits and prevents its binding to the rank receptor on osteoclast precursors, and therefore these osteoclast precursors cannot get converted into mature osteoclasts because this rank L ligand is not binding to it, and therefore because of this dearth of mature osteoclasts, it ultimately ends up decreasing bone resorption. So that is the mechanism of action of Denosozumab. So coming to the next drug, which is the last drug we're going to talk about, is Teriparatide. So what is Teriparatide? So Teriparatide is a recombinant fragment of parathyroid hormone. So this is the only anabolic therapy for osteoporosis. All the remaining therapies actually target decreasing bone resorption by decreasing the osteoclastic activity. So that's the rest of them. So this is the only anabolic therapy for osteoporosis in the sense it stimulates osteoblasts and therefore causes increase in strength of the bone or deposition of the bone. So that is why if you ever get a question saying which is the only anabolic therapy for osteoporosis, the answer is Teriparatide. So it's very important to understand the mechanism of action of Teriparatide because it is often very confusing. Why? Because I said it's a recombinant portion of the parathyroid hormone. So you can be like Dr. Prepper, but parath hormone causes resorption of bone and increase in calcium levels in the blood. Then how can something that acts like parath hormone cause an increase in bone density? So what was discovered is Teriparatide is actually administered as a pulsatile dose. So you give them like subcutaneous injections daily, and this pulsatile dosing of Teriparatide causes a physiological response where osteoblasts actually end up proliferating and maturing. So when osteoblasts proliferate and mature, they cause deposition of calcium into the bones and increase in density. So that increase in bone deposition helps in the treatment of osteoporosis. So that's how this acts. So it's very important to know because it's often confusing. So I just wanted to bring out this nice pictorial representation of to understand the activity of all these drugs that we have spoken about. So first I would like to point out the rank L receptors. As you can see, these are the rank L ligands, which bind to the rank receptor. So these are receptors on osteoclast precursors, which once they bind with these rank ligands, become multinucleated osteoclasts, which get activated and cause bone resorption. So now as you can see, these are the rank receptors. So as you can see, Denosozumab, the monoclonal antibody, is binding to these rank ligands and preventing their binding to these rank receptors. So that is their action. How the bisphosphonates act is they are now integrated in the bone. So once these activated osteoclasts try to resorb this bone, they enter the osteoclast and causes apoptosis. And here is Teriparatide. Teriparatide is the only anabolic therapy, as you remember. So here Teriparatide is causing proliferation of these osteoblasts. Increasing the osteoblasts will cause increase in deposition of bone. So that's just a pictorial representation to help you understand how these different drugs act. Now we will just do a small comparison of Denosozumab and Bisphosphonates. So you might get a question saying what are the similarities between Denosozumab and Bisphosphonates. So the only common similarity is that they both attack osteoclasts. They have an indirect effect on osteoblasts. They have no direct effect. The direct effect is purely on osteoclast. That is the only similarity that they have. Let's look at the differences, which are very important. So let's look at the differences between Denosozumab and Bisphosphonates. So here are the differences between Denosozumab and Bisphosphonates. We've already discussed most of them. So let's look at them again. So Denosozumab remains extracellular, like you saw. It has to remain extracellular so that it can tackle the rank ligands. Bisphosphonates become embedded in the bone mineral. This targets a rank L through the rank OPG pathway it acts. As we know, this targets FPPS or farnesyl pyrophosphate synthase, as we looked at it previously. So Denosozumab now inhibits osteoclast formation, function and survival. Bisphosphonate induces apoptosis of already formed osteoclasts. Denosozumab has a relatively rapid onset of action. Bisphosphonates has to get integrated in the bone, taken up by activated osteoclasts and then it acts. So it has a slow onset of action. So the other is that Denosozumab, very important, is cleared by the reticuloendothelial system. Bisphosphonates are primarily cleared by the kidney. So these, you can get a question from any of these points. So it's very important to know the difference between the two. And individually also from these drugs, you can get a lot of questions.
So that's it for today's video. If you liked the video, please hit that button to share your emotions. Share the video so that others can benefit, and subscribe to my channel if you want to continue receiving such lectures every week. If you want me to cover any specific clinical questions or topics, let me know and I will definitely try to do so. So, keep up the good work and all the best for your NEET.